So much for joining us for today's Lunch and Learn session on nursing leadership in long-term care, challenges and myths with April Huang and Michael Wing. My name is Laura Clark, and I am the Director of Advancement at the Lawrence S. Bloomberg Faculty of Nursing. I'd like to thank Laerdal Medical Canada for supporting this event. Their investment in continuous professional development for the nursing community is very much appreciated. I also wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are very grateful to have the opportunity to work on this land. A couple of housekeeping notes before we get started with today's presentation. We will notice that we do have everyone muted for the time being because of the volume of people that are joining us today, but I do encourage you as we move along in the presentation to put your questions into the chat box, and we will have a time for questions at the end. Secondly, just confirming that we are recording today's presentation so that we can share it with those who are unable to join us. And we will also send the link to all of the attendees today, along with a survey, so we can get some feedback on how you enjoyed the event today. We will also take some screenshot photos during the presentation. So if you do not wish to be in those photos, please let us know or just keep your camera off. Now it is my pleasure to introduce today's speakers. April and Michael are both graduates of the Lawrence S. Bloomberg Faculty of Nursing. April completed her BSCN and her MN in Health Systems Leadership and Administration, and Michael also completed his MN in Health Systems Leadership and Administration at U of T. April and Michael are both now managers of advanced nursing practice for the City of Toronto, Senior Services and Long-Term Care Division. In their roles, they provide clinical nursing service leadership, facilitate advanced clinical care, research, education, consultation, and collaboration to execute, facilitate, and sustain scholarly nursing practice across 10 municipal operated long-term care homes. April and Michael are also excited to be teaching in the new Bloomberg Nursing Clinical Leadership in Long-Term Care Certificate Program that is launching in January 2022 for point of care and frontline nurses, RNs, and RPNs working in long-term care facilities and similar practice environments. Thank you so much for joining us today, Michael and April. I'm going to hand it over to you.
Perfect. Thank you so much, Laura, for that wonderful introduction. And I also want to thank, in addition, Shauna and Carolyn for inviting us to speak about nursing leadership in long-term care, in addition to its challenges and myths. So we'll dive right in. So I will be saying next slide. So we'll go to the next slide. Thank you. So to set the context for our talk, thought it was important to give some background around our career, and Laura has given some details around this already, but it, I think, really gives context for our talk later on, and also around our perspectives around the challenges and myths within long-term care. So both Michael and I didn't start our careers within long-term care. In fact, we're both in acute care. And for myself, I'll start first. I began my nursing career in multi-organ transplant at University Health Network, subsequently completing the Master's of Nursing, Health Systems Leadership and Administration at U of T. And actually, Michael and I were in the same class. And transitioned into an advanced practice nursing educator role at Toronto Western. And so when the pandemic began in 2019 and into 2020, during that first wave, I felt very compelled to help any way I could in long-term care after hearing the news about the situation with COVID-19 that was happening in the long-term care homes. So during that time, I had reached out to my director at UHN to see what I can do. And at the time, UHN was partnering with a much affected site. And so I was redeployed in as a UHN lead. Those 10 weeks, I will say, have changed my life and has really shown me what long-term care is, whereas before I had really no idea or not a huge concept of what it is to work in long-term care. It was extremely humbling. It was, I would say, an extraordinary experience. The 10 weeks felt simultaneously like it went by, within a snap, and also like it was a lifetime. And it really had stayed with me, that experience. And so when the opportunity presented itself for my current position with the City of Toronto, which I've been in now just over a year, it was really that experience, that 10-week experience, that propelled me to learn more. And so that is my background into long-term care. And I'll let Michael go now.
Okay. All right. Thanks, April. First, personally, I'd like to extend my thanks as well to the faculty Bloomberg of nursing as well. And thank you very much, Laura, for that introduction. So my background really stems from acute care. So I've started my role at Toronto General Hospital as a emergency department nurse. I did that for about a few years. And in that department, in the emerge, I started to realize a lot of vulnerabilities around senior care. It's particularly in the emergency department. So I started taking on quality improvement projects in the department, and I just found a passion for addressing those vulnerabilities. Fortunately enough, in 2016, I did get a position at Runnymede Healthcare Center, which I got as a advanced practice nurse in the complex care and rehab unit. And that's where I really, developed my leadership skills in the context of geriatrics and senior care. So when I saw the position open up for the City of Toronto for senior service and long-term care, I thought that would be my best, role and fit into, doing my diligence with senior care and geriatric population. So that's my background, and I guess we can move to the next slide. April and I wanted to offer an overview of our division with the City of Toronto before we start this presentation. Senior Services and Long-Term Care is in charge of service planning and strategic integration of the City of Toronto's senior services. So this includes community support programs such as adult day programs, supportive housing, tenancy supports, homemakers, and other nursing services for vulnerable members in the City of Toronto. And then the final piece is where April and I give our support is directly operating 10 municipal long-term care homes that provide resident care for permanent stay, for convalescent, and short stay admissions. So in our responsibilities, for those 10 homes, we enable, sustain, support scholarly nursing practice across 10 of these long-term care homes by providing our own nursing clinical service leadership, best practices in geriatric care, research, education, and consultation through our hospital partners, through local public health units, the ministry, and so on. Next slide.
So, it's a part of long-term care, and I think as we were learning about this sector early on, and many who are on the call who might have had experience in long-term care, whether leadership related or not, may be already aware of this. But it really struck us how highly regulated all aspects of care are within long-term care. And so I've highlighted a couple of the regulations and also the act, but there is, it's quite a lengthy act and regulation. And essentially all long-term care homes within Ontario are governed by the Long-Term Care Homes Act from 2007, which also includes the set of regulations. The document itself is 90 pages long, in addition to the 141 pages of regulations. And I will point out it is Times New Roman size 10 font. So there's quite a bit of information in there. And I think that's a telling part of how detailed it is also that a guide to this act and regulations created by the government of Ontario is in and of itself 137 pages long. So it outlines in detail everything from doors in the home, its locations, to dress and bedtime routines, to laundry services, care plannings, furnishings, to the resident bill of rights, councils, operation of the homes, funding, licensing, and so much more. So not only is there this act and regulation, but it is upheld by regular announced and unannounced inspections. And so inspectors conduct inspections for the purpose of ensuring compliance with regards to the requirements under this act and also its regulations. So it is quite specific what is proposed and what is displayed by this act and its regulations. So one example I have is that resident beds must have firm, comfortable mattress, and it gives also a measurement of 10.16 centimeters thick, unless contraindicated as set out by the resident's plan of care. So that's just one example of how specific it can get when it comes to these the act and regulation itself. The next slide, please. Thank you. So there are 31 inspection protocols from home-related mandatory tasks. So things like dining observations, family council, infection prevention and control. They are, care plan is really a big part of these inspections. And what they're really looking for is consistency to things like care planning, contraindications that are seen in practice, any omissions, application of practice guidelines, standards, and these regulations. So all of these inspections are publicly available for each and every home. And there are 627 homes across the city, or not the city of Toronto, but across Ontario. And so all of them are absolutely publicly available. The next slide.
Okay, and we also wanted to address the types of nursing leaders that you may see in long-term care. So the long-term care nursing leadership positions that you see here include the following. But just to point out too, I'd like to stress out that these positions are not always associated with our division or with other long-term care organizations. So, and in fact, you actually might see very different role titles. However, these are only a few of the more typical roles in long-term care that you could see, and there could be many more. So you have the administrator, or in the private sector, they call it the executive director. They're in charge of the home's overall leadership and accountability, as well as the operations management and departmental performances. So I want to be clear with that role. You do not need to have a nursing background to be an administrator, but it is certainly a path to follow. Then there's the director of care nursing job, which is responsible for the general management really of the nursing portfolio. You may have divisional managers like April and myself, right? Where you may have a long-term care organization that oversee, more than 3 or 2 or 5 homes in a municipality or in a community. You have nurse managers, you have charge nurses. Charge nurses are usually your frontline nurse leaders on the floors. Educational coordinators, IPAC practitioners, nurse practitioners, and MDS coordinators. Next slide, please. We've broken down 5 major topics of nursing leadership in long-term care in this presentation. The first is the point of care leadership. Point of care leadership examines how nurse leaders in long-term care give supervisory support for managing nursing staff's professional practice and encouraging their teams to focus more on resident-centered care using evidence-based practices. Secondly is the regulatory framework. It's an important component of the nurse leader's function in long-term care. As April has mentioned in her previous slide, it looks at how highly regulatory, legislative, organizational frameworks interact with how point of care leaders work in that environment. So the point of care leader, for example, may conduct audits to ensure ministry regulatory compliance is met. They may provide reinforcement and education, depending if you get a non-compliance order, and participate in policy development to ensure regulatory compliance. Another important role too is the nurse leader's role in promoting high quality practice settings and safe care delivery systems, which is examined in supporting quality outcomes. So nurse leaders in long-term care in particular will be expected not only to promote high quality clinical outcomes, but also they have to balance, positive interpersonal behaviors with staff, residents, and their families, as well as achieving resident-centered care, maintain collaborative working relationships, maintain autonomous nursing practice, and adequate staffing, all in one, when trying to support quality outcomes. When leading teams, the nurse leader demonstrates, making judgments and decisions based on ethical guidance and professional standards. So they create a secure environment in which team members can contribute to their full ability while also feeling appreciated. They'll use techniques like some of you may be familiar, SBAR, daily safety huddles, delegation, conflict resolution, advocacy, approaches to dealing with medication errors, complaints, and escalations of care problems with their teams and families, for example. And then last but not least, the fifth major pillar is partnerships with residents and families. The residents and their families are long-term residents. It is their residence, it is their home. So as a result, one of the most important ongoing and dynamic processes associated with interpersonal and environmental factors in the home is the collaboration between residents and their families and staff. So the nurse leader in the home, they will be in charge of services including care plan coordination, a very welcoming admission process, transfers, assistance in navigating healthcare systems as well. Okay, next slide.
So we've given sort of an outline of the roles and responsibilities of nurses and nurse leaders within long-term care. And I would really argue that any nurses within long-term care is a leader. And there are absolutely inherent challenges within long-term care. And we'll focus on these 4 buckets for the next couple of slides. So 1 around compliance culture, 2 around the chronic shortage of resources, current funding model, and then also its unfortunately negative public image. Next slide. Thank you. So around compliance culture, and we've given a tidbit of the rules and regulations that govern long-term care homes within Ontario. And I think we really try to drive home the point of the fact that it is highly, highly regulated and also very detailed with regards to its regulation. And when we're talking about compliance culture, it is really to do with some of these inspection rules. And also, I think this has been reported by many operators, associations, and labor unions, is that staff can become very focused on regulated tasks. And unfortunately, that is to the detriment of positive resident outcomes at times, and also the residents' own rights, safety, security, or quality of life. So there has been from the long-term care public inquiry with Justice Galeese, where there is a recommendation for long-term care homes to cultivate just culture, where human error is dealt with openly rather than punitively. And when we have a system that is based on compliance, that is based on inspections, it can very much feel like finger pointing. And also this creation of this culture of fear versus one that allows for that just culture. So this unfortunately is part of the system, which hopefully will change in the near future. But currently, because of this type of culture, it does lead to the sense of fear, where this highlight on compliance or avoidance of compliance orders that are made public creates, the sense of fear amongst the long-term care homes leadership and staff. So, when we think about how this plays out for our point of care staff, many times we do hear that they are afraid to report or to make any errors, and are not going to be comfortable coming forward with either their colleagues or any management with incidents. And that safety culture is really, really based upon people feeling that comfort and that psychological safety to report any sort of issues or errors that do happen. We do know human errors happen, but we need to be able to learn from them. And so the compliance culture seems to be in the way of that. Institutionalized style of care, that is one that is part of this culture as well, where when you do have all of these rules, very specific rules guiding care, it does not allow for that emotional aspect of care that is so important when we're thinking about, especially in long-term care, where these facilities and these homes are indeed somebody's home and is where somebody lives for 24 hours a day, 7 days a week. So we do need to have that leeway for staff to bring in things that are outside of perhaps something that is so institutionalized and so structured. Next slide, please. Great. So when it comes to the shortage of resources coming from acute care, Micah and I, often reflect on how well resourced it is within the hospital or the acute care setting. There are often ample professional development opportunities, ongoing training, and access to resources. And previously being a nurse educator, I do see the immense benefit of having that type of role within every unit. However, we know it is a luxury. And when many shifts work short, when there are these audits that must be completed, documentation, conflicts to manage, families to reassure, incidents to review, labor relations to resolve, and staffing schedules to approve. And also, in addition to that, many new ministry directives to read and implement each week, if not daily. It is difficult to introduce roles that do not directly act to solve these very pressing issues. And so there may be a misalignment of resources that favors more so the bureaucracy instead of direct resident care. And I think some of those examples really show that, the pace in long-term care really is anything but slow. There's lots of change and lots of new initiatives that are coming, which is great, but it also requires time and energy and human as well as technological resources. Next slide, please. The current funding model is an important challenge as well. And you may have heard in the news that there is a push to have increased direct care hours, which is a great change in the right direction. So to 4 hours for each resident in the new funding model. On a higher level, without getting into too much of the technicalities and specifics. But there is a multiplier or an adjustment when it comes to funding for each home, which is called the case mix index. And this is a numeric value that's assigned to long-term care homes and is used as a measure of average care requirements for residents based on this minimum amount of data to guide planning and monitoring, which is called RIMDS. What essentially can happen is, the more care needs, the more funding a home would receive. So for example, for residents who require higher activity ADL needs, so activities of daily living needs, IV or intravenous care, various types of behavioral symptoms, the higher that CMI or that case mix index. And so the higher the funding. In theory, this makes quite a lot of sense. However, one thing that comes up is there a way for us to have funding that also incentivizes positive outcomes or higher quality care? Because the current system can unintentionally incentivize poor outcomes. And so I think this is a worthwhile conversation to have, not to say that we have any concrete solutions at this time, but I think opening up that conversation is important. Next slide, please. And then absolutely negative public image. And, this is something that we hear in the media, not only just lately when it comes to the pandemic, but even prior to as well. It is hard convincing new grads many times to work within long-term care. And I think this messaging begins even prior to starting nursing school. Long-term care is generally perceived as a less desirable career choice in comparison to acute care. And this perception, when we're thinking about it and trying to break that down, can relate to factors, for example, social devaluing of elders or elderly care, a media focus on the issues and problems and many challenges of long-term care rather than the many, many stories of success. Longstanding issues when it comes to the culture within the long-term care and the healthcare sector that places more respect and value on hospital-based settings. And also perceptions, and Michael will get into later around myths, but the perception that long-term care is, lower paying or physically much more challenging, or having work being undervalued when compared to other sectors. Those are all perceptions that I think hinder people from joining this sector. And so the proliferation of all of these perceptions negatively impact those who maybe would desire to work here, and also deter individuals from really considering a career within long-term care. And so, I think what long-term care really needs is a better public image and better public relations, maybe, to help attract more interest from not just nursing, but really every healthcare profession. And that includes our physician partners, that includes our, physiotherapists, our occupational therapists, and many of our allied health. And this is definitely one of the largest challenges within long-term care. Next slide. Thank you. So right now, it is such an exciting moment within Ontario. This article actually just came out in Toronto Star a couple of days ago, and it highlights exactly what we have discussed. So the lack of resources is Byzantine, and I'll quote there, regulatory structure. Lisa Levin of Advantage Ontario, as their CEO, states it so well. If the government eliminates the old institutional style of care, residents could enjoy their final years pursuing individual interests, such as painting or gardening, with the freedom to eat and sleep on their schedule, not the rigid times dictated by legislation. And really, this is where, as nursing leaders, we need to step up and join this conversation. Next slide, please. So we have also heard many reports and inquiries and many other questions posed around what the challenges are, but also importantly, what the solutions can be. And the message is loud and clear that there must be some changes, and there must be some changes within our current structure. So in one of the commission reports, Honorable Frank Morocco had talked about this investment in infrastructure that needs to happen. And I would say across the board, when you read any of these inquiries and commission reports, that is one of the focus. But what he also highlights is that now is the time to revisit the delivery model and think about what is a better way to provide care for Ontario seniors. A great document from the CNA when it comes to 2020 vision is also to think about our philosophy of aging within Canada and to open up those conversations with the population because the changes are happening and it is important for the public to be involved. I really like a particular quote from Frank Morocco's commission report, where he states that leaders at every level must put their hearts as well as their minds into reimagining the care of elderly in this province. And this will require a philosophy of care that is anchored in respect, compassion, and kindness for the people who work and live in long-term care. It's not just about building more homes, but there needs to be transformation to a person-centered care model, which motivates different behaviors and rewards innovation and leads to better outcomes for residents and staff. He calls for a multi-dimensional approach for this transformation. We also need effective leaders and strong leadership. The long-term care specific education modules that are being developed by U of T in the Center for Professional Development is a means for developing this knowledge and capacity. And we will need more when it comes to this type of education. Also, they highlight, I'll say, the value of nurse practitioners because their distinct skill set and hands-on approach being leveraged during the pandemic was especially helpful. And they are such a valuable resource. And in that report as well, they had explicitly stated that this is something that should be continue to be deployed within long-term care and long-term care homes across the province. Next slide, please.
All right, so let's get on to the myths. Here are some of the main 4 myths that April and I thought were important to address. So the first one, number 1, is there are fewer professional opportunities in long-term care. Second one is it is where nurse leaders choose to retire because it's easier. Number 3, I will lose my leadership skills if I spend most of my time in most of my career in long-term care. And number 4, it is a boring work environment. Next slide. So let's start to debunk myth number 1. The first one, leaders in geriatric excellence. The need for healthcare professionals trained in geriatric, principles is escalating. There hasn't been a higher need than now. In order to meet the growing challenge of our aging population, many organizations like hospital-based settings are starting to discuss being senior-friendly as a strategic priority. Thus, long-term care is an excellent pathway to encourage new nurse leaders to specialize in geriatric services to achieve better health outcomes for our seniors. Being leaders in geriatric care means being leaders in cognitive and behavioral disorders, self-care capacity, falls management and prevention, palliative care, case management skills, the 3Ds, delirium, dementia, and depression. Variety of nursing leadership roles. There are a variety of leadership roles in long-term care. There are formal positions of authority, and then there are informal influence. New graduate nurses, new graduate registered nurses will tell you that they will achieve leadership experience earlier on than their other, colleagues that are new grads in hospital-based settings. When you are a new grad RN working on a home area of a long-term care home, you will likely step into a lot of leadership roles and decision making the first week. If you are passionate with administrative and health information technology, you can move on to RIMDS in long-term care. If you are passionate with infection control, you can have experience of being an IPAC lead or an IPAC practitioner. If you are passionate with managing responsive behaviors, you can have an experience leading the behavioral support program in our homes. And then this one's an interesting one: exposure to private and public homes. Long-term care is in Canada, at least, is subdivided for profit and not for profit. And then there's public homes, which are municipal. So it can give you experience whether or not you want exposure working in corporate business of caring for seniors, or public funded business of caring for seniors. Next slide. Debunking myth number 2. It is where nurses choose to retire because it's easier. First thing, it does not get easier. It is challenging, but it's very rewarding. Working with residents who exhibit responsive behaviors requires you to be very flexible and adaptable. So just leading into that, residents' moods can be highly variable at any time, and staff will look to you for guidance as a nurse leader. So they will need your strong analytical, critical thinking skills to make sound decisions very quickly. Secondly, you will form strong bonds with the residents and their families and the caregivers in long-term care. In my opinion, long-term care sector is probably the best environment for you to develop your customer service standards when compared to any other healthcare sector. The skills you acquire, such as conflict resolution with patients, residents, and families, can be applied elsewhere. It is really the only sector that recognizes nurse leaders working in residents' homes, providing direct care and services while indirectly serving family members. And then thirdly, managing clinical programs and outcomes. So, from the charge nurse to the director of nursing, they are all held accountable for outcomes measurement. They are all publicly accountable for the outcomes, from submitting resident assessment data to completing quarterly clinical program evaluation. So again, they're just, accountable for their outcomes at a public level. So imagine that on top of your shoulders while supervising an entire home and everything else we've mentioned prior to this. It requires a great deal of, not easy prioritization as well. Next slide. Debunking myth number 3, I will lose my leadership skills if I spend most of my career in long-term care. So depending on the different situations in the home, nurse leaders will use different types of leadership styles to respond to the situation. So there may be days where you will have to be a coach, you may have to be assertive, you may need to be highly motivational, collaborative, or even authoritative. So as a nurse in charge, especially for new nurses, as I mentioned earlier, they have to make critical judgments right away sometimes. And really, they are the only ones in the building who have the authority, particularly evenings and night shifts. Effective interpersonal skills with staff. So again, these residents are here long-term, right? These are their homes. So nurse leaders need to be able to create a good living environment for the resident, while at the same time trying to help their colleagues and teammates navigate these interpersonal dynamics and maintaining safe quality outcomes as well. So, as you already know, long-term care setting has, unique conflicts involving staff, residents, and interpersonal dynamics. So everyone who works in a long-term care to community, from administrator to the dishwasher, there will be conflict, right? So especially with the home, especially with the ones that live in the home, since you will be working with, long-term care residents and families, you will be able to develop, early detection of conflict symptoms that facilitates, interventions that enhance positive outcomes too. So early detection of conflict is, very key to conflict management. And then last but not least, I think long-term care is great to really hone and strengthen your skills in prioritization and time management, because there's so many, number of activities in the homes or number of activities at a divisional level. Nurse leaders in long-term care will appreciate time management and prioritization. Nurse leaders will appreciate that it's essential to prioritize and establish, good approaches to ensure residents are treated with dignity and respect. Because whenever you are trying to prioritize anything, uh, long-term care really reminds you that residents are at the center in any type of decision making or prioritization for that matter. And next slide, our last debunk. It is a boring environment. Every day is different and unpredictable. When you think you're going to perform, your daily tasks that you're scheduled for the day, you'll likely not you'll likely not do that task. Things can turn on a dime at any moment, and every, director of care nursing will tell you that, or anyone in the home. You may have to report a few documents to head office, but a code yellow was just called, or you are assigned to conduct, training and education to a group of 10 people, but now you have to address a resident or family complaint because, they're at the center of the care. So very unpredictable, very different every day. The nature of the work is very different as well. The nature of work is very much multitasking, all for the benefit of the resident. Sometimes you're wearing multiple hats because of this. The interprofessional team, for example, they may try to collectively solve a problem on a single issue to a number of diverse residents in the home. So the nature of the work is not the same as a nurse leader would, let's say, in a surgical unit, where you may be there to address a patient complaint about a wound dressing. But in long-term care, you think you may be addressing a resident complaint about a wound dressing, but you must approach it, holistically. And sometimes perhaps you're addressing behavior, family dynamics, etc. And then, last but not least, it's not a boring work environment because there is job satisfaction here. Now, depending on a few different other factors with job satisfaction, because that's a huge concept in itself, nursing leaders, organizational and professional commitment have been associated with job satisfaction in long-term care. The commitment includes relationship building. That's what we found in our research. It's relationship building with staff, residents, and families. They start to become like your family. Nursing leaders love to see residents happy and being engaged. And I think that's honestly one of the greatest things, especially from this pandemic. You especially recognize what a great team you work with and how everyone has made a difference and how everyone has come all together for the resident. All right, next slide.
Yeah, so we wanted to end off with a couple of highlights. I think, with outlining some of the challenges and also debunking some myths, you can see that it is a highly complex workplace. It is getting higher in acuity too, which also relates to, higher level of skill set. And then also when it comes to that job satisfaction, that last point that Michael was making, you end up, and this is one comment that I hear a lot from staff, you end up feeling like your family, a lot of times with the residents. And that is something that is so unique within the sector that I haven't seen in acute care. And so I think when we think about that job satisfaction, it is also knowing that, day after day, you're seeing very consistently same residents, same individuals, and you get to build these therapeutic relationships over a longer term period. So the needs are changing, and it has been changing over the past many decades. And also what we need to realize too is that the nursing leadership and the education we give must also evolve with it. The funding and staffing models must also change in order to keep our long-term care residents safe and to also support our nurse leaders to maintain high quality outcomes. We know that by 2030, 1 in 4 Canadians will be 65 or older. And so there is an urgency for us to build these skills and knowledge that are required to care for one another. So we need to build these opportunities to grow within long-term care and also beyond wherever their interests lie. And really, it is such an amazing and an exciting time and a moment of change with the legislation from 2007 up for review. That this is a prime opportunity for us to take this time to carve out what the future will look like, and also the futures of countless individuals. The next slide.
All right, so the next slide is our last slide, and we just wanted to end it off with the question, are you sure? So April and I were talking about this, and we kind of found out there were some commonalities prior to us entering long-term care. So as you know from the beginning, April and I came from acute care, complex care, etc. And everyone asked us prior to our first, day at the City of Toronto Long-Term Care, are you sure? Are you sure you want to go into long-term care? And some of the things were, you will not get things done there, Michael. They are so slow. Why would you go there? Right? So we took a giant leap of faith, right? And, when I heard that comment, you will not get things done there. And I'm just thinking to myself, perhaps that's the type of mindset that does not encourage new, inspiring nurse leaders like myself to change our health system for the better. So, ever since going to long-term care, I am most proud to have developed and applied change management principles and a variety of leadership styles across, these long-term care homes. From expanding the scope of practice of all of our registered nursing staff, RNs, RPNs across the 10 homes. We are just about, we've ensured our RPNs can do hypodermoglysis. Now we're just about to embark on an intravenous program to ensure our staff know how to maintain IVs to prevent ED transfers. Like, these are exciting programs I am so excited to be part of. Even prior to the pandemic, we were able to change the way we do things with relation to IPAC, leveraging technology to assist with, monitoring IPAC activities, increasing our audits. We used to be doing annual hand hygiene audits before I came, introducing an interprofessional approach to do home-to-home audits, where other city homes can audit other city homes with IPAC. And another huge step, right? Another huge step ahead of some hospitals in Ontario, our division fully rolled out electronic healthcare records across our 10 homes. So these are just some of the many, many, things that I am proud of, that we're proud of getting things done ever since joining long-term care. And we are not done yet. So there's just so much more potential for excellence in seniors care.
Absolutely. And I would echo everything Michael has said. Those were so many questions that were asked before even taking this opportunity. Are you sure? Is it, are you going to be bored? Is this something that you really want to head into? It might be difficult to, have opportunities anywhere else. I think those are all things that we had listened to and really tried to process before making the leap. But just as reflected from Michael's experience, it was a leap, but it was absolutely, I feel, a right decision in terms of being able to build on my own skills as well with all of these different areas, project management, as Michael has said, and really improving and going forward when it comes to the scope of practice of our nurses. It's a lot of change, and it's a lot of great changes that have been made and also are to come. And I think what we would like to challenge all of you who are listening on the line, whether you are a student or whether you are already in a privileged position of being a leader in your field, that thinking about the skills and your own biases when it comes to long-term care, and the next time that a resume lands in your lap with a long-term care experience, really thinking about what that means and also what that skill set of the individual is. I think if we're all able to take that step back and to really think about what presumptions or assumptions we have about the sector, then we can also move forward in improving the level of care and the level of our nurses, as well as other health professions within long-term care. All right, next slide, please. Thank you all so much. We really appreciate that you are taking this time out of your lunch break to have this conversation with us. And we will be very excited for the next 8 minutes to answer any questions you have.
Thank you so much, April and Michael. Does anyone have any questions? Oh, we have a question coming in. How many of the 10 municipal homes have specifically addressed 2S LGBTQ+ cultural safety through a formal safe space process? Sorry.
Yeah, absolutely. I think there's lots of forums, and we are embarking on that and really focusing first on an environmental scan and to get everyone's feedback before moving forward with specific initiatives. And there are specific areas within City of Toronto that are geared towards making sure that we are acknowledging all of the challenges when it comes to LGBTQ2S. And so it is definitely a big part of the values of City of Toronto to ensure that all of these groups are recognized, and also what, again, some of the presumptions and assumptions, how they leak into our everyday practices.
Yeah, and just to add to answer that question, we do have an LGBT program implemented across the 10 homes. 2 of our homes particularly focus really heavily on the LGBTQ population, and actually have a lot of LGBT population in the homes. Fudger House, True Davidson Acres. In fact, actually about 5 years ago, Fudger House celebrated their 50 years of pioneer work in long-term care, particularly being the trailblazer in care for LGBTQ seniors.
Thank you. Thanks for the question, Diane. Does anyone else have any other questions for April or for Michael? Getting some great feedback in the chat here, but everyone appreciating your presentation. And I will echo, this person just said that you both certainly emulate the cultural change that is needed in long-term care. I think that's a great compliment. I think that's very true. Does anyone else have any other questions before we wrap up today? One more question here. Are for-profit homes here to stay? And how do LYC homes retain PSW hirees when not able to provide adequate care to the numbers assigned to them?
That's a great question. And what has been interesting through the pandemic is they have taken a look at the numbers for numbers of outbreaks and how pandemics, as well as for inspection protocols and the inspection reports, if there is a difference between for-profit and not-for-profit homes. The interesting piece is that there is not a significant difference within these two. And when we take a look at the commission report as well, because of the huge need for additional beds for long-term care residents in the future and also currently, there is a sense that there has to be collaboration of for-profit and not-for-profit. So the model that was proposed is for those who have the monetary means of putting forth the money essentially to build a long-term care home, that these investors need to be involved. However, the homes need to be run by those who are passionate about long-term care and are passionate about this sector. And so, there has to be some sort of a collaboration between these two pieces so that we have those who are passionate running the homes. However, those who have the means to put, an investment into building additional homes need to also have a return on their investment. And so that partnership, I think, in the future will become more and more important. But it does seem at this point that, for-profit homes are likely here to stay.
Yeah, and I just like to add, from that question, it just really depends on the political landscape of where long-term care ought to be. Depends on the governments too. We have an election coming up next year with the provincial. It depends what their plans for retention of PSWs will look like. Are we going to look at mandated ratios? What's the education ongoing? What's the current funding model going to look like, as April mentioned earlier as well? So just reading the chat box here, right? It's the government will have to make the decision as well, right? Whether do we want to continue private, for-profit homes, or move away from that?
Mm-hmm. Yeah, that will be definitely a huge part. And we've seen an increased amount of funding and investment into long-term care just within the past couple of years. And when it comes to, increasing the numbers of those who are going through school to become a PSW or to become an RPN or an RN, we're seeing a lot more incentives given by the government for those to either stay in the profession or to join the profession. And so I think that will be an important part of the strategy going forward to attract more individuals into this area.
Mm-hmm. And I think the sector is in a great place. It's in a terrific timing, as advocacy and the movement is now. The timing and the public outcry over the pandemic is now. So the change will be supported.
Thank you so much to both of you. And thanks to everyone who tuned in today. We really appreciate your time. Thanks for joining us. And thank you again, April and Michael, for sharing all of your knowledge with all of our alumni. We really appreciate it. If you are interested in learning more about Bloomberg Nursing's Clinical Leadership in Long-Term Care Certificate Program that April and Michael will be teaching in, please visit our Center for Professional Development website. We'll also send a link out to that to all of you after this presentation. Also, stay tuned for our next Lunch and Learn happening on Tuesday, November 16th, featuring the research of Dr. Charlene Chu, talking about technological interventions to improve the lives of older adults. So a related topic that I think many of you will be interested in. So thank you again to Shauna and Carolyn as well in the background. Thank you, April and Michael, and thanks to all of you for attending. Hope you have a great rest of your day. Thanks very much.
Thanks, everyone.
Thank you. Thank you, everyone.